All right, let's jump right into this massive 2023 AMA guideline overhaul for hospital inpatient and observation care. Looking through all this source material, it's incredibly clear that this update was a complete paradigm shift for how we code these encounters. Seriously, it changed the game. We're looking at a unified code structure that simplified the rules and shifted the focus entirely over to medical decision-making and time. Here is our roadmap for today's explainer. We're going to hit the 2023 guideline overhaul, initial care, subsequent care, the tricky same-day admit and discharge rules, discharge day management, and then we'll wrap up with audit red flags. Starting off with Section 1, the 2023 guideline overhaul, merging two worlds. This was the historical consolidation that completely transformed hospital coding. Before 2023, inpatient and observation were treated as two entirely separate beasts, but not anymore. So here's the absolute crucial point. Those legacy observation codes, like 99217 through 99220, and the subsequent ones, 99224 through 99226, they are totally gone, deleted. What replaced them is a beautifully unified code range from 99221 to 99239. And this is key. Observation status is now strictly defined by the level of clinical care the patient actually requires, not by what physical floor or unit they happen to be sitting on. As long as the clinical care level dictates observation or inpatient status, it all falls under the exact same family of codes. Moving right along to Section 2, initial inpatient and observation care. Let's look at the patient's actual admission. This perfectly illustrates the new rhythm of coding. History and physical exams, they're no longer the driving factors for your code level. They just need to be medically appropriate. Instead, for the principal admitting practitioner, you are picking your code based entirely on either the medical decision-making level, the MDM, or the total time spent on the date of the encounter. It's a dual track. So for 99221, you're looking at straightforward or low MDM, or 40 minutes of total time. Bump that up to 99222, and you need moderate MDM or 55 minutes. And for the highest level, 99223, you need high MDM or a full 75 minutes. It's just so much cleaner. Now, we have to talk about a very common scenario. What happens if your patient starts out in the emergency department, gets evaluated, and then ultimately gets admitted to observation or inpatient status? How exactly do we code that same-day site of service transition? Well, the rule of thumb here is that those prior services, like an ED visit or an office visit by the same provider on the exact same date, they just roll right into the initial hospital care code. Generally, you're only reporting that initial hospital code, like a 99221 or 99223, and the guidelines are very clear. Be extremely careful about unbundling here. The ED visit is only reported separately if you have the clear, rock-solid documentation to support a modifier 25 for a significant, separately identifiable service. If you don't have that, it's all bundled. Okay, Section 3, subsequent care and daily rounds. These are your codes for daily progress reporting on those multi-day stays. Just like with initial care, we lean right back on those dual tracks. You pick your code based on either the MDM complexity or your time thresholds. So for a stable patient or one who's improving, that's going to be a 99231, which is straightforward or low MDM or 25 minutes. If they need a moderate assessment or some treatment tweaks, you're looking at a 99232 at 35 minutes. And for those really significant new issues or high-risk decisions, it's 99233, which requires high MDM or 50 minutes of time. Let's dive into Section 4, same-day admission and discharge. Honestly, this is where things get really interesting, specifically how we handle the edge case of patients admitted and discharged on the exact same calendar date. Enter the notorious 8 to 24-hour rule. This one trips up a lot of people. If a patient's stay is under 8 hours on the same calendar date, you only report the initial care service, those 99221 through 99223 codes. You absolutely do not report a discharge code. But if the stay hits that magical 8-hour mark and they are still discharged on that exact same calendar day, a brand new set of combination codes suddenly unlocks. And here they are. For those 8+ hour same-day stays, you use the combined admission and discharge codes, 99234 through 99236. And again, you're looking at your MDM or your time thresholds. 99234 needs 45 minutes, 99235 requires 70 minutes, and 99236 requires a full 85 minutes, or a high MDM. These codes wrap up the whole shebang, everything from the very first evaluation all the way through to the final discharge paperwork for that day. If you keep the AMA logic straight in your head, it actually flows perfectly.
Less than 8 hours? Initial care only. 8 or more hours on the same date? That's your 99234 through 99236 combo codes. But if they get discharged on a completely different calendar date, no matter how many hours it's been, you revert back to using separate initial care and discharge codes. It is absolutely crucial to keep that logic pinned to your workstation. Next up, Section 5, Hospital Discharge Day Management. This is for the end of a standard multi-day stay, when the patient leaves on a date subsequent to their admission. Now, unlike the initial and subsequent codes that give you that MDM or time option, discharge codes are strictly time-based. No MDM track here, it's actually super simple. 30 minutes or less, bill 99238. More than 30 minutes, bill 99239. The most vital thing to remember is that this is cumulative time. It encompasses all the non-continuous time spent that day. So the final exam, discussing the stay with the patient, giving instructions to the family, finishing up the medical record, and writing out those final prescriptions. All of it counts. Finally, we reach Section 6, Audit Red Flags and Compliance. We've built the whole story of the patient's stay, but we really need to talk about what happens when these rules get misapplied. These are your big hitter audit triggers, right here. First, you literally cannot bill initial care multiple times per stay for the same physician specialty. It is reported once per admission by the admitting doc, period. Second, like we talked about earlier, unbundling a same-day ED visit without rock-solid Modifier 25 documentation is a massive red flag. Third, if you're claiming more than 30 minutes for a discharge using 99239, that exact time has to be strictly logged in the chart. No guessing allowed. And lastly, you gotta drop that legacy observation mentality. Observation is a clinical status now, not a location. Ensuring your physician's documentation clearly supports the admission status versus observation is just absolutely vital to protecting your revenue and passing those audits. You also have to explicitly document total time if you're billing based on time, and make sure those discharge notes are fully fleshed out in the chart. Mastering these time thresholds and that tricky 8 to 24-hour rule is definitely your ticket to keeping billing pristine under this new system. It's a huge shift, but it does leave us wondering, as medical decision-making becomes the center of gravity for coding, will this ultimately lead to much better patient care documentation, or are we just going to see more administrative focus on watching the clock? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.